Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast. Today, we're looking at a challenge that's, notoriously difficult in oncology: pancreatic cancer.
It's a tough one. The survival rates are low, largely because it's so often diagnosed at a late stage. But there's this tantalizing possibility on the horizon, using artificial intelligence to catch it much, much earlier.
Right, but moving that from a research concept to a clinical tool is a huge leap. That's exactly the gap today's paper is trying to map out.
It is. We're discussing a review article from the Korean Journal of Radiology, published in 2026, titled From Bench to Bedside: The Path Toward Real-World Translation for Artificial Intelligence in Pancreatic Cancer Detection.
The path. That word choice says a lot. It suggests a journey with obstacles, not a simple switch to flip.
Precisely. The paper isn't just celebrating what AI can do, it's a very sober look at what it will take to actually get it into clinical practice. At a high level, the core problem is that early-stage pancreatic tumors are incredibly subtle.
Give me the numbers on that.
The paper cites an estimate that small, potentially curable tumors, those under 2 centimeters, are missed up to 40% of the time on imaging.
40%. Wow. And we know the survival numbers are stark. The 5-year survival rate is around 13% overall, but it jumps to 44% if the disease is caught when it's still localized.
Exactly. So the dream here is opportunistic screening, using AI to scan the background of every routine abdominal CT done for any reason, like kidney stones or back pain, to see if those subtle, early signs of pancreatic cancer are present.
Okay, so the paper reviews the current state of these AI models. What have they found? Broadly, what are the categories?
The authors break it down into 3 main types of models. First, there are the straightforward detection models, designed to find existing tumors on CT scans. Second, and this is where it gets really interesting, are the pre-diagnostic models. And third are models for characterizing pancreatic cysts.
Let's start with direct detection. How good are these models?
They're surprisingly robust. One model mentioned, called Panda, was developed on non-contrast CTs. In a real-world deployment on over 16,000 patients, it detected 95.5% of pancreatic ductal adenocarcinomas, or PDACs.
That's a strong sensitivity. But the key question is always, how does it stack up against radiologists?
Well, another study, the Panorama trial, did a head-to-head comparison. The AI model achieved an AUC of 0.92, while 68 radiologists averaged an AUC of 0.88.
So statistically superior. And what does that mean in practice?
At the same level of specificity as the radiologists, the AI found 38% more cancers, and conversely, at the same sensitivity, it cut the number of false positives by 38%.
Okay, that's a meaningful difference. So that's direct detection. You said the second category was pre-diagnostic models. Define that.
This is the idea that AI can detect signs of developing cancer on CT scans taken months or even years before a visible tumor actually forms and a clinical diagnosis is made.
Hold on. You're saying these are scans that were, presumably, read as normal at the time.
That's right. The models aren't seeing a distinct mass. They're picking up on incredibly subtle, distributed changes in the pancreas, things like parenchymal atrophy or shifts in tissue heterogeneity and texture.
What's the lead time we're talking about here?
It's remarkable. One study using a CNN model demonstrated an AUC of 0.97 for pre-diagnostic detection with a median lead time of 475 days.
475 days, over a year before diagnosis. That's a massive window of opportunity.
It is. Another radiomics-based model found measurable differences with a median lead time of 398 days. It suggests the biological process is underway and leaving a faint digital footprint long before it's visible to the human eye.
Fascinating. And the third category was cyst models. What's the problem they're trying to solve?
The challenge with cysts is figuring out which ones are benign and can be left alone versus which ones are high risk and might need surgery. It's a common dilemma.
And the AI helps with that risk stratification?
It does. A systematic review found that AI models reached a median AUC of over 0.91, often outperforming established clinical guidelines. One prospective study was particularly telling.
What did it find?
AI assistance improved radiologists' diagnostic accuracy, with the mean AUC climbing from 0.786 to 0.845. It also reduced the average reading time by over 23%, and importantly, in a real-world cohort, it corrected 5 out of 11 malignant cystic neoplasms that had been initially missed by radiologists.
So it made readers more accurate, faster, and caught potentially critical misses. That's a compelling combination.
It is. So when you look at all three of these model types together, direct detection, pre-diagnostic, and cyst characterization, the performance on the bench is very, very impressive.
Okay, which brings us to the second half of the paper's title, the bedside. The performance is there in the lab, but the review makes it clear that real-world implementation is the real challenge. Where do the barriers start?
They start with the data itself. The paper flags the continued reliance on single institution datasets as a major barrier.
Right. A model trained at one hospital with its specific scanners, protocols, and patient population might not work well at another. Generalizability is the classic problem.
Exactly. And this is especially true for those subtle pre-diagnostic models, which are hypersensitive to what the authors called domain shifts. Things like a scanner upgrade could completely throw the model off.
So the first hurdle is building robust, multi-institutional and longitudinal datasets for training and validation.
Correct. But even with a perfectly generalizable model, you run into a huge statistical problem.
The low prevalence of the disease.
You nailed it. Pancreatic cancer is rare, roughly 14 cases per 100,000 people. If you apply a highly sensitive AI model to the entire general population, you're going to generate an overwhelming number of false positives.
It's the needle in a haystack problem. You'll end up with a giant pile of hay and very few needles. That would create a massive downstream burden of follow-up scans and patient anxiety.
It would. The paper points to a survey where over half of radiologists said they'd only accept up to 5 false positives for every true pancreatic cancer detected. An untargeted approach would blow past that limit.
So what's the solution? We can't just not use the tool.
The paper advocates for a very clever, pragmatic solution, a tiered risk approach. It's laid out really nicely in their Figure 3.
Walk me through the tiers.
Instead of pointing the AI at everyone, you first filter the population. Tier 1 uses broad clinical risk factors: age, diabetes patterns, family history, social history. This creates a smaller, somewhat higher risk group.
Okay, that makes sense.
Then, Tier 2 applies another set of filters using data from the electronic health record, or EHR, things like weight trends, comorbidities, or lab markers like CA19-9. This enriches the cohort even further.
And only then, on the smaller pre-screened higher risk population, do you unleash the AI model. So Tier 3 is the AI.
Exactly. The AI is applied only to the enriched cohort where the pretest probability is already higher. This helps manage the false positive rate and makes the whole approach more practical and cost-effective.
That's an elegant solution. It treats the AI not as a magic bullet, but as a powerful final step in a structured screening process. Okay, so we've solved the data problem and the prevalence problem. What's next?
Workflow integration. Even the best model is useless if it's disruptive to clinical practice.
What does a bad integration look like?
Think of a disruptive pop-up alert that interrupts radiologists' flow. Too many of those, especially if some are false alarms, lead to alert fatigue.
The boy who cried wolf effect. People just start ignoring the alerts altogether.
Precisely. The authors emphasize that successful deployment requires seamless integration into existing packs and reporting systems. The output needs to be clinically actionable, not just a raw probability score, but maybe a triage flag or a recommended next step.
This all sounds complex and expensive, which brings us to the financial barriers.
They are non-trivial. There are the upfront costs for licensing, infrastructure upgrades, and cybersecurity, but the bigger issue, as the paper puts it, is the hard return of investment problem for early detection tools.
What do they mean by that?
The economic benefits of catching a cancer early are huge, but they are diffuse and realized over many years. They don't show up neatly on a hospital's quarterly balance sheet. This makes it hard to justify the immediate concrete expense of implementing the AI system.
And reimbursement models for AI are still in their infancy.
Very much so. So you need to address data, prevalence, workflow, and finances. But let's say an institution manages to do all of that. They get the budget, they integrate the tool, and they go live.
The journey's still not over, is it?
Not even close. Now you enter the post-deployment phase, which comes with its own set of challenges. The first and critical one is model decay.
The model's performance degrades over time.
Yes, the clinical environment is dynamic. The hospital buys a new CT scanner, imaging protocols are updated, the patient population shifts. All of these things can cause a model's performance to drift downward.
So it's not a set-it-and-forget-it technology. It needs continuous monitoring.
It absolutely does. The paper stresses the need for performance dashboards, predefined triggers for when a model needs to be recalibrated, and a clear governance framework for managing these updates.
And what about the human side of post-deployment? Clinician trust and acceptance.
That's a huge factor. The black box nature of some of these deep learning models can be a barrier. If a clinician doesn't understand at some level why the AI is making a certain prediction, they'll be less willing to rely on it.
The paper also brings up the risk of automation bias. I see two sides to that coin.
Go on.
On one side, there's the error of commission. A radiologist is on the fence about a finding. The AI says it's suspicious, so they overcall it, even if the AI is wrong.
Right. And on the other side?
The error of omission. The AI gives a case the all clear, and maybe the radiologist's vigilance drops. They might be less likely to spot a subtle abnormality that the AI also happened to miss.
Both are serious risks, and it leads to a longer-term question about skill erosion. If clinicians become too dependent on AI for certain tasks, will those diagnostic skills atrophy over time?
That's a tough question to answer without long-term data. The last barrier the paper mentioned seems related: evolving standards of care.
Yes, concept shift. Diagnostic guidelines change. A model trained to classify cysts based on 2020 guidelines might be obsolete or even misleading by 2027 if the criteria change. The model's life cycle has to be tied to the life cycle of clinical knowledge itself.
So if we pull back, the paper paints a picture of incredible potential paired with a formidable implementation pathway. The science of the models is advancing much faster than the science of their implementation.
That's a perfect way to put it. The key takeaway for me is that the next big breakthroughs in this field might not be an AI model with an even higher AUC. The breakthrough will be a system that successfully solves this entire clinical AI lifecycle.
From multi-institutional data ecosystems and tiered risk workflows to robust post-deployment monitoring and clear financial models.
Exactly. The challenge has moved beyond just building a powerful algorithm. It's now about engineering a reliable, trustworthy, and sustainable clinical tool that works in the messy, dynamic reality of healthcare.
A clear and sobering roadmap. That concludes this episode of SummaryCast.